Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. In today's episode, Dr. Howard Lee from Baylor College of Medicine in Houston, Texas, Dr. Tatyana Kushner from Weill Cornell Medicine in New York, and patient advocate Andrew Reynolds discuss strategies to overcome barriers to HCV testing and treatment in sexual and reproductive health clinics. This episode is part of a larger educational program on simplifying screening and treatment of viral hepatitis in priority populations. For more information on Drs. Lee and Kushner and Andrew Reynolds, along with a link to the larger educational program, please visit the link in the show notes for this episode. Now let's get started with Dr. Lee.
So the CDC just in their annual report in 2022, that it's actually the first year that we've seen the case of the reported acute cases in year 2022. It's actually the first year that the acute cases has decreased, despite we all know that the direct antiviral therapy has started, available around the year of 2014, 2015. So I think it's good, thing to see that we finally see the going down of the acute, estimated acute infections and actual reported acute cases. However, if we look at the detail in the CDC report about the documented risks and behaviors for exposures in this acute hepatitis C cases, of course, we know that injection drug use is still on the top of the reported risk. However, I also want to direct your attention to other risk behaviors and exposures, such as multiple sexual partners and men who have sex with men, and some other sexual contacts, also very top on the reported risk behaviors and exposures. We're going to talk a little bit about what's the actual hepatitis C prevalence among men who have sex with men. There is a study published in 2019, look at the global data and including 194 studies who have men who have sex with men between year 2000 and 2019. And the pooled hepatitis C prevalence is 3.4%, with a 95% confidence interval 2.8 to 4%. I also want to discuss a little bit detail about the study, but it did show that in men who have sex with men that have living with HIV, their pooled hepatitis C prevalence is even higher, up to 6.3% compared to those does not live with HIV. Also, the other important finding according to this study is that people using HIV PrEP, the men who have sex with the men who are using HIV PrEP also have a much higher HCV incidence, according to the study, compared to those that do not use HIV PrEP. Next, I'm going to have Tatyana going to talk us about the Hep C prevalence among pregnant people in the US.
Thank you, Howard, and thank you everyone for joining. So we also have had increasing amount of data specifically about hepatitis C prevalence and incidence in pregnant people. And there now have been a number of studies done in the US and different regions in the US. The study that was published a few years ago and looked at hepatitis C specifically among pregnant people over time. And what you see clearly here is that from 2009 to 2019, there's a significant increase of hepatitis C cases diagnosed in pregnant people. And specifically, we're seeing that the increase is seen particular in non-Hispanic white individuals. And overall, per this study, hepatitis C and pregnancy went up from 1.8 to 5.1 per 1,000 live births. Now, of course, this can and hopefully does reflect increased screening or testing for hepatitis C in the context of pregnancy, but also reflects a true increase in prevalence that we're seeing. The study that was published earlier this year that looked just at a single tertiary clinic in Appalachia. This is a region in the country with high hepatitis C prevalence, largely related to the opioid epidemic in that region. And in this particular study, they found that hepatitis C positivity among pregnant people was 12%, which is quite high. So over 1 in 10 people in this study had evidence of hepatitis C, suggesting that the pregnant patient population is a key population to be thinking about when we're talking about screening and intervention, and of course, linkage to care. So let's talk about hepatitis C screening and what are the current recommendations and practices around hepatitis C screening overall. So these are the current recommendations from the AASLD-IDSA. So this is the Liver Society and Infectious Disease Society. And this is the hepatitis C guidance regarding screening. So the clear recommendation is that universal hepatitis C screening is now recommended for all individuals at age 18 and over, and all individuals less than 18 with increased hepatitis C infection risk, which of course includes the adolescent subgroups of the adolescent patient population. In addition, prenatal testing is recommended for hepatitis C for each pregnancy. So each pregnant individual should be tested for hepatitis C with each pregnancy. Furthermore, periodic annual testing is recommended in individuals at increased hepatitis C infection risk. So annual hepatitis C testing is recommended for all persons who inject drugs. It includes HIV-infected men who have sex with men, and it includes men who have sex with men while taking PrEP, which Howard was discussing in the beginning.
What other activities and other conditions and circumstances that was associated with a higher risk of hepatitis C infection? So the risk activities are current or past injection drug use, or intranasal illicit drug use, such as using nasal cocaine, and or use of glass cracked pipes that can also increase the risk. And also, as we discussed, a man engagement sex with other men that can also have been identified as increased risk behavior as well. And then chemsex, which is in some certain men who have sex with men population, and also some straight population as well, that also has been identified as increased risk of hepatitis C infection. There are other conditions and circumstances like also associated with a higher risk of hepatitis C infection, such as HIV or hepatitis B infection. The person that about to start HIV PrEP. Again, some other chronic hepatitis and/or chronic liver disease, including unexplained ALT elevations, and our solid organ transplant recipient and donors. That can also in the condition that's increased risk of hepatitis C infection. So just to emphasize about, especially in some of the men who have sex with men population, there are some risk factors, and also including non-men who have sex with men population as well, about the risk factor for sexual hepatitis C transmission. So I think oftentimes we forget about the possibility of sexual transmission for hepatitis C. So there are several categories, kind of risk factor that we need to think about. First is the sex practices that can cause trauma to rectal mucosal tissue and rectal bleeding, such as receptive anal intercourse without a condom or receptive fisting. Also, sexualized drug use, like we talked about earlier, chemsex or party and play, or used substances such as crystal methamphetamine, mephedrone, gamma hydroxybutyrate, or phosphodiesterase type 5 inhibitor before or during sex are also has been associated with increased risk. Last but not least, if the person have presence of ulcerative and rectal sexual transmitted infections, such as syphilis, lymphogranuloma, venereals, and genital herpes, those also have increased, has been identified as having increased risk for sexually hepatitis C transmission as well. Now that's back to the AASLD IDSA hepatitis C guidance again about hepatitis C testing and prevention in men who have sex with men. First of all, as we mentioned earlier and by Tatyana, that this group has been identified as higher risk of hepatitis C infection. So the current guidance does recommend that test for hepatitis C annually for men who have sex with men. It's regardless of their HIV infection status. We also do need to provide patient counseling as well about the risk of sexual hepatitis C transmission, including the sexual and drug use practice. Lastly, it's really important to educate our patients about hepatitis C infection or transmission and talk about prevention measures. But again, I want to remind everyone when we approach our patient, please, we do need to be aware of the implicit bias, and we need to have a very culturally sensitive approach as well. Next, I'm going to have Tatyana is going to talk about hep C screening in pregnancy.
Great. Thank you, Howard. So we'll move on to specific recommendations around hepatitis C screening in the context of pregnancy and prenatal care. So why do we care about hepatitis C during pregnancy? Why is this a key population to have dedicated counseling and approach to management? Well, there are a few different aspects that are specific to pregnancy where hepatitis C is quite relevant. And among them are the issue of mother-to-child transmission of hepatitis C, but also the question of whether having hepatitis C in pregnancy can actually influence the health and outcomes of your pregnancy. A meta-analysis published this year, which focused specifically on hepatitis C in pregnant people. And this was a global study that pooled data from a number of studies from around the world addressing hepatitis C in pregnancy. Overall, they did find quite a high prevalence of hepatitis C. There may be some bias there in terms of studies included. But when they looked specifically at the risk of mother-to-child transmission, they found that there's a risk of around 9% when they pooled the data from all of these studies. So to my knowledge, this is the most updated estimate of the risk of transmission from mother to child. And when we speak with patients, oftentimes the biggest concern in people who are pregnant is the health of their baby. And the risk of mother-to-child transmission is important to share in order for the patient to be informed about risk and consideration for possible interventions to decrease that risk, which we'll discuss later. And then in regards to adverse pregnancy outcomes, there have been a number of studies that have looked at the association of having hepatitis C during pregnancy with pregnancy outcomes. A study that we conducted using a large database in Canada, where actually what we looked at is specifically individuals who had active hepatitis C viremia during pregnancy compared to those who may be hepatitis C antibody positive, but were cured in the past. So were not actively viremic during pregnancy, to really try to get at what is the influence of having the virus present during pregnancy on pregnancy outcomes. And what we found is that there was a significantly increased risk in those people with active hepatitis C during pregnancy of preterm pregnancy delivery, almost a 5-fold increase in the risk of a condition called intrahepatic cholestasis of pregnancy, which in turn is associated with negative outcome, potentially adverse outcomes in the fetus. Also, we noted an increased risk of postpartum bleeding and intrauterine growth restriction. So this study, among others, suggests that having hepatitis C during pregnancy can be associated with worse pregnancy and neonatal outcomes. So those are two of the reasons, and here are a few other reasons about the importance of identifying hepatitis C in pregnant people. It's important to note that oftentimes the pregnancy encounter or prenatal care is the initial or the only encounter with the healthcare system in individuals who are otherwise of childbearing age who are otherwise healthy and may not seek care or have a regular primary care follow-up, for example. So this is a reason where it's really important to screen in this context and then link to care, because you may not see them again encountering the healthcare system after the pregnancy care period. In addition, it's important to counsel individuals who screen positive for hepatitis C in pregnancy or are known to have hepatitis C prior to pregnancy about the risk of the adverse pregnancy outcomes and risk of mother-to-child transmission that I mentioned. In addition, identifying hepatitis C in pregnant people can help to diagnose children early. So if there is transmission to the infant, then it is imperative to test the infant to determine if transmission occurred, and then subsequently, if it did, link those children to treatment for hepatitis C. And quite important is the idea of linkage to care. So if we are screening during pregnancy and identifying hepatitis C, we need to have systems in place to make sure that we link individuals to treatment of their hepatitis C, whether it is during pregnancy, as we'll discuss later, or more commonly postpartum. So as a result of all of these considerations, there has been consensus really among all the major societies over the years about the importance of universal screening in pregnancy. Previously, the recommendation had been for risk-based screening, meaning only screen pregnant individuals if they have reported known risk behaviors. But over the years, our guidelines have been updated to recommend universal screening. Back in 2018, the AASLD-IDSA initially made the recommendation, but after that, there really was not too much uptake because really most of the care of individuals who are pregnant occurs in the obstetric care setting. And so really it took a few years after that for the American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine to also make these recommendations, which also were endorsed by the CDC and USPSTF. And now there's a clear consensus that there should be universal screening for hepatitis C during each pregnancy, regardless of risk factors. And it's one thing to make a recommendation for screening, in particular in populations such as the pregnancy population, but it's quite another to implement. And I think we'll get to this in the discussion when we talk about potential barriers to implementation. And this is data that now was published in, a few years ago in 2022, but it looked at actual implementation of hepatitis C screening in the prenatal care setting. And this was a study that looked at Quest laboratory data, a national look to evaluate who incorporated hepatitis C testing in their prenatal care panels. There has been an increase in hepatitis C screening in pregnancy, especially around 2020, 2021, when the guidance began to be updated. But still, as of 2021, it was really less than half who were screening for hepatitis C in pregnancy. I do think that probably by now, and I hope the rates are higher, but clearly the study showed that there was still room to go. And the authors concluded that despite progression in a pregnant person screened for hepatitis C, current testing rates fall short of universal recommendations. So now I'll turn it back to Howie to discuss how do we actually screen and what are best practices for hepatitis C screening.
Thank you, Tatyana. Now we're going to talk about hepatitis C test algorithm, and some of you may be very familiar with this. So, now currently our first step is checking for hepatitis C antibody. If it's negative, it's non-reactive, then no further test is needed. But if the person have positive hepatitis C antibody, then we'll do hepatitis C RNA. Ideally, it should be a reflexive testing. If there's no hepatitis C RNA detected, then that meaning the person does not have current hepatitis C infection and the person had prior hepatitis C infection. However, if the person have a positive hepatitis C RNA, that meaning the person have current hepatitis C infection, and then we need to link this person to Hep C care. However, we all know that from diagnosis to treatment, there could be a long journey for some of our patients. So, the patient come in, visit one to see a provider that found to have anti-Hep C antibody, and then they need to go get the lab test. So will be a visit two with a phlebotomist and get the testing. And the antibody test may take a while to come back, can up to 1 to 2 weeks sometimes in different places. And then the provider will receive the diagnosis at visit 3. And then we need to order more testing to confirm the RNA as we talked about. So the patient needs to have another visit with a phlebotomist. And then we need to wait for the result of RNA coming back and then finally get the diagnosis and make the treatment plan. So there's a lot of, steps in this traditional pathway in terms of Hep C diagnosis and treatment. This was considered one of the major barriers to Hep C elimination is lost follow-up. Because if patient lost follow-up any of the steps, the patient will not receive the Hep C treatment. So now there's a lot of discussion. Now we have really good treatment for hepatitis C. Now, so a lot of discussion, gearing towards to the potential role of reflux nucleic acid testing and point for care testing. And we're going to have some discussion in our talk today as well. Now, the point of care Hep C RNA testing, I'm going to talk a little bit more about that. It does allow for diagnosis and treatment in one visit. It has been, in some pilot study, has been implemented successfully in various settings, such as correctional facilities, such as prisons, mobile clinics, community clinics, needle syringe programs, and overdose prevention sites. And compared to the standard of care testing, this point of care is testing associated with first, reduce time to treatment initiation, and second, increase treatment uptake, and third, reduce loss to follow-up. And then this is a potential very powerful tool, especially when we think about our marginalized communities, such as men who have sex with men that we talked about today. So, a very exciting update is in June 2024, just several months ago, the point of care Hep C RNA testing is approved. And again, it's an automated finger stick PCR test. The turnaround time is within an hour. So we think this will become a very powerful tool moving for Hep C elimination, especially in men who have sex with men and a lot of marginalized communities as well. So there's have been studies looking at the Hep C testing in the non-traditional sites. So, for example, this study was done also in the South Appalachian region of the US recently between 2017 and 2019. Look at non-targeted hepatitis C screening and linkage to care programs developed in 10 different institutions in that area, such as emergency room, medical clinics, health department clinics, syringe exchange programs, correction facilities, and FQHCs. There's still a very high positive rate of hepatitis C positive screening in all these facilities. And the rate of linkage of care is also can be pretty high in a lot of the settings. So that kind of, confirm us that in order to achieve the Hep C elimination goal, I think it's really important to go outside of the traditional sites. And I think there's a lot of outreach need to be done, as shown by the study. Now we're going to talk about testing for hepatitis C reinfection, especially in men who have sex with men. Why this is important in this population? Because study has shown that there's high hepatitis C reinfection rates reported after Hep C treatment and cure among HIV-infected men who have sex with men. It's around 7.3 to 15.2 per 100 person years. And then for sexually active men who have sex with men, after successful treatment or spontaneous clearance of Hep C infection, we do still recommend tests for Hep C at least annually and risk-based if indicated. If your patients have very active unprotected sex, as we talked about, and or other substance use, then this frequency might need to be increased as well. If the patient already got treatment, then hepatitis C antibody is no longer a test that we can use for test for reinfection. Then we need to use Hep C RNA testing in this scenario. Now I'm going to have Andrew. He's going to talk us about Hep C prevention for men who have sex with men.
Thanks, Howard and Tatyana. That was a great summary of hepatitis C screening and options for men who have sex with men and pregnant folks. So just really quickly, one of the roles that I play as a health educator, patient advocate, whatever we want to call, is around the education around hepatitis C prevention, especially for men who have sex with men. I think there's a really key role that health educators, peer navigators, allied health professionals, whatever you want to call us, can play in educating folks around all the stuff that we've been talking about thus far. So I think really kind of elevating awareness around the things that make us more vulnerable to hepatitis C. So condomless anal sex. We know that hepatitis C can be transmitted from blood-to-blood contact. And so during anal sex, there could be tearing and bleeding. And that also applies to anything that could lead to quote unquote rectal trauma, fisting, vigorous sex toy play, long periods of sex, sometimes with drugs or without drugs, that could lead to more friction and more tearing and more bleeding. And so talking to people about harm reduction techniques and sexual practices, staying hydrated, increasing condom use, wearing gloves for fisting, switching out condoms on sex toys and that type of play. All of those things would create a barrier that would prevent hepatitis C infected blood from getting into a person during sex. I think it's also important to highlight the work of Dan Fier. Dan and his team found infectious levels of hepatitis C in some men who have sex with men who are living with HIV, in their semen and in their non-bloody rectal fluids. So making sure we educate folks around that as well. This is especially important for PrEP, right? Like we have PrEP to prevent HIV. We don't have a PrEP for hepatitis C. We don't have a PEP for hepatitis C. So educating folks around that. And then I think, an understanding about the relationship of sexualized drug use, knowing how to refer people. SBIRT, the brief screening, referral and treatment, is a really nice way to kind of address substance use quickly and effectively. And then knowing your harm reduction services in the area, your syringe service programs. Are there places that distribute crack pipes or crystal meth pipes and that type of thing, as well as linkage to drug treatment programs, both inpatient and outpatient. So next up, we'll have a little discussion with the faculty. An easy way to kind of get rolling on this is to talk about some of the barriers to hepatitis C screening. Not enough staff time, limited appointment availability, competing priorities. I definitely feel that one. Stigma and privacy concerns. Stigma around hepatitis C is an absolute barrier for people to talk about testing. Lack of knowledge from providers and patients. That's definitely something that comes up. Cost, lack of insurance, limited availability of the rapid test. And then this one's a big one too, an inability to refer to treatment. You test somebody, they're positive. Oh, how do I hook somebody up to primary care? So what do you, Tatyana and Howard, what do you guys think about some of these barriers and how your clinics have overcome them?
It's a great summary, actually. Those really do seem the key barriers. I think in the obstetric care settings, all of them do apply, but one important one, especially I think, is the idea of referral to treatment. So, if we diagnose someone with hepatitis C during pregnancy, what are the options for treatment? Does it have to wait until after pregnancy? Can we consider it during pregnancy? And more importantly, who will be doing the treatment? So if we are screening, there has to be a very clear pathway within the healthcare system or whatever other setting to make sure that we know what the next steps are. Otherwise, it, puts kind of this responsibility on the person who screened and puts them in a position where they don't know what to do next. I think that's really a key one, to make sure that once you implement screening, to have a clear pathway in place to link to care.
Yeah, I agree with Tatyana. And I think in the men who have sex with men settings, that I think one of the key factors I identified is actually some of the more LGBTQ focused primary care providers. There are probably some of them might not be familiar with the repeat testing annually. That guidance from the IDSA and ASOD, as we discussed, because that's kind of connected historically. Hepatitis C was not considered a sexually acquired infection. So, and sometimes when we kind of forget about it, that we need to test for that, especially like Andrew nicely described, in certain men who have sex with men population with their sexual practice, they does have a higher risk. So I think from the men who have sex with men settings, I think the education for both providers and patients are very important too.
Excellent, excellent. How about we move to the last one, the potential role and barriers to point of care testing and HCV RNA testing?
So I think that's a really exciting field. As Howard mentioned, just this year, this point of care testing was officially approved in the US by the FDA, which is a big step towards actually implementing. And I think similarly to what we said about screening, also specifically with point of care testing, one thing is the approval, and the next thing is where and how will you implement it effectively to actually help you work towards the goal of hepatitis C elimination. I think that internationally, for example, in Australia, this has been done very well, but in the US, it's new. And so I think this year we'll be learning a lot about different practices and their experiences of implementing it. And there are specific settings that I think that this will be a game changer. And then there are other settings where it may not make such a big difference, such as, for example, in the obstetric care setting, typically there are frequent touch points with the healthcare system anyway. So there may be less of a role for just a one-time touch point for hepatitis C diagnosis, but perhaps in some settings there will be.
Yeah, I do think in terms of men who have sex with men population, I think this is an amazing tool and going to be a very powerful tool that I can foresee. As a lot of you guys probably aware that in men who have sex with men populations, there has been HIV point of care testing and has been used. And that's actually accepted by a lot of men who have sex with men populations. And then some of them even have the kid in their home. So, I think adding this Hep C point of care testing, I think it's since a lot of our men who have sex with men, a group that already have experience doing point of care testing. And so I think this will help, the providers and patients testing more for hepatitis C. And then that will, I'm also very excited about this, and I can see that will improve the Hep C elimination, especially in this subgroup of people.
Yes, I'll add, I do Hep C testing and treatment at a syringe program and a sexual health clinic here in San Francisco. And I have dreams of rapid testing somebody, antibody positive, running a point of care RNA test. During that hour, doing health education, collecting, locating information, health insurance information, and then eliminating that 1 to 2 week period waiting time to get that RNA test so we can move faster on linkage to care.
And there's actually one question in the Q&A which is directly touching on this. Actually, one person asked, do you see insurance providers denying typical screening through point of care testing for hepatitis C? So maybe Andrew, do you see that this may be a problem in the foreseeable future about denying the point of care testing?
I hope not. And I know there's a lot of people like the National Viral Hepatitis Roundtable and other advocacy organizations who are working really hard to make sure that that doesn't happen. And if we are going to be committed to eliminating viral hepatitis, I think this is going to be an essential tool. And there seems to be a significant amount of buy-in federally to support this. And I think that will trickle down to the rest of us.
I hope so as well.
Yeah. Let me wrap up with some key take-home points for everyone. So, we in the first part of our seminar today, we talk about screening. So I just want to highlight some key take-home points. First of all, sexual and reproductive clinics should provide Hep C screening and linkage of care. We should test for hepatitis C in all adults at least one time. For people who use drugs, HIV-infected men who have sex with men, and men who have sex with men receiving PrEP current recommendation is at least annually testing. For pregnant people, we should test for each pregnancy. For individuals at increased risk, we should also consider testing periodically. And to improve our Hep C screening, we should consider screening at non-traditional sites, including the reproductive health clinic and pregnancy clinic, as we talk about. Also, use of reflex RNA or point of care Hep C RNA testing, as discussed in the last session. Also, additional Hep C testing to a prenatal screening panel has been shown to be an effective intervention as well. Lastly, after SVR, sustained viral remission is achieved, screen at least annually for reinfection, especially in those with ongoing risk, is also important, as we discussed earlier. So we're going to talk about Hep C goals of treatment here. As we know, that goal of Hep C treatment is sustained virological response or biological cure, you may say, which is continued lack of detectable Hep C RNA for equal or greater to 12 weeks after therapy completion. Fortunately, and now we have really, really good treatment. All oral regimens associated with up to 99% of SVR rates after 8 to 12 weeks of treatment, which is similar rates among people who use drugs. Based on the USPSTF evidence review, sustained viral response associated with decreased risk of liver-related mortality, hepatocellular carcinoma, liver cancer, and all-cause mortality. So this is a really important outcome we're trying to achieve with our treatment of hepatitis C. All right. So now I'm going to just briefly go over the AASLD IDSA Hep C guidance for simplified treatment for treatment-naive adults without cirrhosis. So the eligible patients, including adult with chronic Hep C, any genotype, and no cirrhosis, and no prior hepatitis C treatment. And patients who have any of the following characters will not be eligible, including prior hep C treatment, cirrhosis, hepatitis B surface antigen positive, current pregnancy, non or suspect HCC, liver cancer, and prior liver transplantation. So if the patient is eligible for this simplified treatment, the recommended regimen, including glecaprevir, previnaspir, they need to be taken with the food, and the duration is 8 weeks. The other option you can have is sofosbuvir and viloprevir. The duration is 12 weeks. And for people that with compensated cirrhosis, if they have no prior hep C treatment, they are also eligible for a simplified treatment if they are treatment naive. So, but we need to notice that there's if they have any of the following, they will not eligible for this simplified treatment pathway. If they have present or past decompensation from their cirrhosis, or they have end-stage renal disease, they have hep B surface antigen positive, current pregnancy, non or suspect liver cancer or prior liver transplantations, as we discussed earlier, those people are not eligible. So the recommended regimen, if they are genotype 1 to 6, are glecaprevir, previnaspir, need to take it with the food with duration of 8 weeks, the same duration. If they are genotype anything but genotype 3, so if you have genotype 1, 2, 4, 5, or 6, you can also use sofosbuvir and viloprevir. Duration will be 12 weeks. If the patient with genotype 3, you need to do baseline NS5A RS testing if required. It's required. If without Y93H, can receive this treatment as well. So why is it important to treat for hepatitis C for in the men who have sex with men? It's not just for individual benefit, it's actually also to prevent hep C transmission in this group of people. Men who have sex with men and who have HIV hepatitis C co-infection are an important population for hep C elimination through treatment as prevention. So efficacy of hep C treatment as prevention in this population is supported both by modeling studies and real-world data. I do want to mention to everyone that simplified hep C treatment is effective in people with HIV on antiretroviral therapy. Even people with HIV, they're still qualified for simplified approach for treatment for hepatitis C. But we need to require awareness of potential drug-drug interactions. There's a very helpful resources I usually share with my colleagues and patients too. It's a Liverpool hep interactions. So, before you start treatment, that's something that I will recommend everybody look it up. All right. So let's go back to the treatment of acute hepatitis C in men who have sex with men population. What are the real-world data showing? So this is one of the more well-known study regarding this. According to this study, the 50% decrease in acute hepatitis C incidence actually was noticed from year compared to the one that without treatment. So as you can see, acute hep C in 2014, the incidence rate is 1.1% per year. And then after the universal DAA access and screening in this population, that decreased to 0.55% per year. So this real-world study did show that, treatment as prevention, especially in men who have sex with men population for hepatitis C. Lastly, I'm going to do a quick summary about the HCV care continuum, the intervention to preserve benefit of hep C cure. So first of all, we talked about diagnosis extensively in the first part of our talk, and we also talked about linkage of care. And then during this period as a provider, I think we do need to talk about, we need to consult our patient on transmission and reinfection risk. We need to linkage to not just for hep C care, also need to linkage to harm reduction according to each risk profile of the patients, especially for men who have sex with men, drug use screening, brief intervention, refer to treatment as needed, talk about condoms, as Andrew mentioned, behavioral intervention as well. And once the patient in treatment and the cure, post-cure care is also important because we talk about there's higher risk of infection in this group. Also, linkage to harm reduction, as we mentioned earlier, and linkage to hepatology care. I do want to mention, especially for people that have F3 or F4 fibrosis, the HCC surveillance, the liver cancer surveillance, will need to be continued in this group of patients. In all men who have sex with men, as we discussed earlier, the infection surveillance annually, at least, is also recommended. All right. Now I'm going to have Tatyana talk us about Hep C treatment in pregnancy.
Great. Thanks so much, Howie. So I think the guidance for hepatitis C treatment in pregnancy is a little bit less clear-cut, but I'll show you where we are currently in the field and really what are the considerations for hepatitis C treatment in pregnant people. So what are the current recommendations from the official guidance panels, the AASLD IDSA guidance? And what it says is that despite the lack of a recommendation, treatment can be considered during pregnancy on an individual basis after a patient-physician discussion about the potential risks and benefits. So this guidance really points to the importance of joint decision-making in this setting in order to determine whether to proceed with DAA treatment during pregnancy. Furthermore, women who become pregnant while on DAA therapy should discuss the risks versus benefits of continuing treatment. So in this context, there may be a discussion, which is probably the only context where we have the discussion of potentially not continuing treatment once someone becomes pregnant if they are already on treatment. What does the Society for Maternal Fetal Medicine say? They say that we recommend that DAA regimens only be initiated in the setting of a clinical trial during pregnancy, and that people who become pregnant while taking a DAA should be counseled in a shared decision-making framework about risks and benefits of continuation. So I would say this guidance is a little bit less supportive of treatment, stating that really, if you are to consider treatment, it should be in the setting of a research trial where perhaps there's closer monitoring and follow-up of patients on these medications. So when we think about the idea of offering DAA treatment during pregnancy, in the absence of clear guidance, as we just saw, we really need to consider the potential benefits and maybe potential downsides of offering hepatitis C treatment during pregnancy. The potential benefit is that we can offer maternal cure while the individual is actively engaged in pregnancy care and healthcare. So use this opportunity to actually cure the individual of their hepatitis C. Furthermore, there's a potential that if we cure the hepatitis C, we can decrease the risk of mother-to-child transmission and potentially improve pregnancy outcomes if what we've seen earlier shows that having hepatitis C actually may increase the risk of pregnancy-related complications. Furthermore, you can offer treatment while there is insurance coverage. Pregnant people have insurance coverage and may lose insurance coverage after pregnancy delivery. So this is a time where they have coverage and you can treat. And of course, from a public health perspective, treat the person in front of you in order to decrease community transmission. However, there are individuals that are not in favor of treatment in pregnancy, and that's because if we are to treat in pregnancy, we want to make sure that human safety in pregnancy is clearly established, and also safety during breastfeeding is established. Furthermore, we do have availability of DAA treatment for children starting at age 3. So some would say, why offer treatment during pregnancy? Even if there is mother-to-child transmission, you could just treat the child later. And also the question of cost effectiveness always comes up when we're thinking about implementing new interventions or treatments. In addition, it's important, especially if we're incorporating joint decision-making in deciding about DAA treatment in pregnancy, to understand the patient and provider perspective. And we do have some data on patient and provider perspective on hepatitis C treatment in pregnancy. A few years ago, back in 2018, we conducted a survey of women with hepatitis C, and they were women who were being seen at UCSF and also women enrolled in the Women's Interagency HIV study. And we asked them whether they would be willing to take DAA treatment in pregnancy. And this was really before we had any data on DAAs in the context of pregnancy. And actually, even back then, 60% said that they would take DAA treatment if it lowered the risk of mother-to-child transmission. So again, the priority here was to optimize the child's health and to decrease the risk of transmission. A lower number said they would take DAA treatment if it provided self-cure, but did not offer benefit in the way of decreasing vertical transmission. And then more recently, there was a study done by Ravi Javeri and colleagues actually performing a qualitative investigation of obstetricians and patients to understand the themes in regards to their considerations for hepatitis C treatment and pregnancy. Obstetricians and people living with hepatitis C had different considerations, but there was some overlap in their thought process about treatment and pregnancy, which included cost and access of DAAs in pregnancy, insufficient obstetrician knowledge regarding hepatitis C treatment during pregnancy, and always the priority here is the question about safety. Whenever we offer any medication during pregnancy, we want to make sure that it is safe. And what is the data that we currently have? So I mentioned back in 2018, when we did that initial survey, we really didn't have any data. But fortunately, since that time, we have had accumulation of data, specifically of DAA use in the context of pregnancy. And this is actually quite rare because there are not many conditions where we specifically study medications in the context of pregnancy. Oftentimes, we just extrapolate and use medications in pregnancy that may have never been studied specifically in the context of pregnancy. But this is the data that we currently have. We have 2 phase 1 studies that have been completed, one using sofosbuvir velpatasvir and one using sofosbuvir adipisphere. And both of these studies have shown that all of the individuals who were treated in pregnancy and second and third trimester of pregnancy who completed follow-up had SVR12. So they had cure and really no signal towards adverse outcomes in the infants. And now there's a huge effort that is currently underway, which is the STORK trial. And this is a phase 4 study which evaluates the use of sofosbuvir velpatasvir in pregnant people with the goal to recruit 100 individuals for treatment in pregnancy in this study, and really to accumulate the level of data that would allow both patients and providers to feel comfortable with the use of these medications in pregnancy in regards to safety and, of course, efficacy. In addition, there's a study that will be starting soon that is also looking at the other main regimen, glecaprevir pibrentasvir, during pregnancy. So really, at this point, we are accumulating data on both of the main regimens in the context of pregnancy in order to inform guidance. Furthermore, there is a registry that is currently online, which is called the Treatment and Pregnancy for Hepatitis C Registry, TIP-HEP-C. It was started by the Coalition for Global Hepatitis Elimination. And the goal of this registry is actually to accumulate real-world data on DAA exposure in pregnancy so that we can accumulate data both from clinical trials as well as the real world. In addition, some practices have implemented hepatitis C treatment in pregnancy. This is data from our own practice where we have been offering hepatitis C treatment in pregnant people with joint decision-making as recommended by AASLD IDSA guidance. And it shows our early results where we ended up treating 7 individuals during pregnancy. And we found that 6 of 7 who came to SVR12 visit did achieve SVR. However, really a big learning point here was that there was a huge drop-off in the postpartum period in terms of engagement and care. So many people did not show up for their SVR12 visit because they were lost to follow-up, really emphasizing the importance of the protocols in place to make sure that people are engaged in care, not just during pregnancy, but also in the postpartum period. And there are different strategies that have been looked at in order to improve this engagement in the postpartum setting. There's some data that suggests that among pregnant people with hepatitis C receiving medication for opioid use disorder, so the high-risk population, only 1/3 start on hepatitis C treatment and less than 10% are linked to care in the 6 months post-delivery. And a few programs have really tried to improve these rates of linkage. The study was a retrospective study of over 300 pregnant people with hepatitis C, and they provided mother-infant linkage to care and co-located care and found that they had a significantly increased likelihood of linkage to care and hepatitis C treatment initiation in this co-located care model. In addition, patient navigation programs can be very helpful in this setting, where a navigator can have frequent touch points with the patient to make sure that they're linked to care, particularly in this postpartum period. So now I'll turn it over to Andrew. Of course, it's great that we're recommending treatment, but how do we really optimize adherence to hepatitis C treatment?
Thanks, Tatyana. Yeah, pills don't work if we don't take them. And the better we take our pills, the better the treatment and cure outcomes are. And, these hepatitis C meds are actually a little bit forgiving for a missed dose here and there, but we want to encourage our folks to get as close to 100% adherence as they can. Very complicated, very few people, we forget these things happen. So I think working with folks, and again, this is another key role that a health educator or a peer can play in your practice. Checking in with somebody about their routines. Every morning I brush my teeth. I'll keep my pill bottle next to my toothbrush, or those Metasets, pill boxes. Those types of things are really, really good, so that I know, okay, it's Monday, here's my pills. Tuesday, pills. Wednesday, wait a minute, I didn't take Tuesday. That way you can kind of see if you missed a dose and keep going. Keeping your meds visible, if that's an option for you, is a really good thing to do. Again, it's kind of that routine. Every morning I make my coffee, put the pill bottle next to the coffee maker. For folks who have access to technology, cell phones, smartwatches, what have you, using apps, using reminders, that's also a really nice way to kind of keep you going. Side effects for these meds tend to be, mild and much easier than certainly the earlier treatments for Hep C. But still, preparing somebody for this, like there might be a little bit of nausea, there might be a little bit of gas and stomach upset. Letting a person know about that so they're aware of it and how they can kind of mitigate some of those side effects will help them get through that little stretch. Following up, you don't have to check in regularly. We have some folks who come to our place and take a pill daily. We have medication lockers. It's really helpful for our unhoused folks. But having a nurse follow up within the first week or so, hey, how's it going on your first week taking these meds? That type of thing. And then I think being mindful of pill burden and maybe treatment length. Maybe I'm freaking out about too many pills, so one pill for 12 weeks, I'm good with that. Or maybe 12 weeks freaks me out, 3 pills for 8 weeks will be something that I feel like I can do. If you can tailor the treatment regimen to the person's needs, that too will help improve adherence. All right. Well, we're on to the discussion session. And I think very similar to our previous, I'll give a little summary of some of the barriers for treatment. Suffice to say, cost, insurance coverage, challenges with receiving hepatitis C medications through specialty pharmacies came up. Social barriers, this is big for the population that I work with, transportation, being unhoused. So you can't send medications to a participant. People might have competing priorities. Once again, stigma, patient reluctance to start. I don't know if you all have heard, I'm not going to do that hepatitis C treatment. Interferon will kill you. The social memory of interferon is still out there for some folks. What are some other barriers that you all find in your medical practice?
I mean, when we talk specifically about pregnancy, again, there's still a little bit of a gray zone there. So the stigma is still a part of it. So recognition of hepatitis C in pregnancy and taking medications for it during pregnancy for sure, as well as really there's not that much data. So really having that joint decision making is crucial in order to help the patient decide what they hope to do.
Yeah, and then in my practice, I think, and I saw on the chat, there's a lot of, our participant mentioned about the insurance restriction. I do still feel like, that's a lot of times that could be a barrier. Some of them still require genotype testing, although the patient met the simplified criteria. So, stuff like that. I think, there's probably a lot more work to do on the our stakeholder side as well to see if we can simplify the pre-authorization for Hep C treatment.
Actually, to that point, there is one question in the Q&A that asks, will insurance pay for simultaneous HCV antibody and HCV RNA in a previously HCV negative individual, or do they want an HCV antibody positive before they will pay for an HCV RNA?
I personally have not had any issue, especially if the patient you're suspected about reinfection. If you document that the patient had been treated before, and then now you have, because of patient meets some risk factors and then you're worried about reinfection, I do not see. I personally have not have insurance company refuse to directly pay for Hep C RNA.
I agree. I've never had an issue with insurance coverage. Obviously, the most typical test that we send is the hepatitis C antibody with reflex to the RNA. So the RNA does come after that antibody. But again, in those with a history of hepatitis C in the past, you do want to start with the RNA. And also, I think since you mentioned risk factors, there was one question about risk factor, and maybe Andrew, you can address it. It says, can you please clarify why using glass pipes is considered a risk factor in people who inject drugs?
Yeah. So, Hep C is transmitted from blood-to-blood contact. So we know sharing of syringes, sharing of injection equipment, that's the potential of HCV infected blood from getting into me. For pipes, there could still be some blood-to-blood contact. It's not going to be as efficient as a syringe, but if I have bleeding lips, bleeding gums, and I hit a pipe and I have hepatitis C, some of my blood gets on the tip of that pipe and I give it to my partner who also has bleeding lips or bleeding gums, and some of my Hep C blood can get into them and then infection can occur. Hep C is a real tough virus. It lives outside the body for long stretches of time. One study found it infectious 16 days outside of the bodies. A couple of others, maybe a little bit longer. Heat doesn't kill it very efficiently. So pipes through bleeding gums, herpes outbreaks, burns can provide a point of transmission for hepatitis C. So in San Francisco, we actually do hand out bubble pipes and straight pipes, bubble pipes for crystal meth, straight pipes for crack. And then we have little pipe covers. So if a person doesn't have access to a new pipe, they can switch out a pipe cover. So that way there's no blood-to-blood contact from lip to lip, lip to pipe to lip.
Yeah, I agree with Andrew. There's actually the data is not as robust for nasal or oral crack transmissions, but there is some study there's one in CID in 2008 that noticed that Hep C RNA can they detect the Hep C RNA in the pipes that be used. So there's definitely a potential risk of transmission. Most likely through the blood, as Andrew mentioned about because a lot of people using nasal cocaine will have mucosal damage on their nose, so they're easily to have blast along with the secretion. So that's definitely a possible transmission route.
Right. Actually, there's another question related to just hepatitis C prevalence that maybe we can address quickly now. It said, did the studies that looked at hepatitis C prevalence among men who have sex with men control for the fact that men on HIV care or PrEP might have a higher prevalence just because they are screened more? So my question is really, are men in HIV or PrEP care really at higher risk than other men who have sex with men? Or are they just more likely to be diagnosed with hepatitis C due to screening practices? Great question.
Yeah, I think that's a great question. And that study is actually very well done. They collect data from all over the world. I do not think they mention about how frequent that each group has been testing. I think it's depends on, because it's a meta-analysis, so it's a little bit harder to look that data. Depends on probably not all the study they included. They report that type of data. I mean, there's a possibility that increased testing frequency did increase your diagnosis rate, but I do think as we can see, the prevalence and incidence has to be a lot higher. So I do think, even adjusted for that, again, I don't think it's adjusting that study, but even adjusted for that, I do think there is still a potential higher risk in the men who have sex with men population. So I think that's why all the guidance now that has some special address to that population as well. But I think that's a good question, and that's something we can consider in the future study that see if we can control that effect.
Thanks.
So quickly, one of the other things about hepatitis C, we're much better about Hep C education now in the DAA era than we've ever been. But there are still sort of misconceptions on hepatitis C prevention, testing, and treatment. And so we've addressed many of these. You can't get hepatitis C from sex. As we've seen, there are certain individuals in certain sexual health groups that have a more vulnerability to sexual transmission of Hep C than some others. So being able to talk to folks about that, I think, is really important. You can't get Hep C from blood transfusions. We've been screening blood since July of 1992. So blood transfusions in the United States are safe. This one comes up, Tatyana mentioned this one. Folks think vertical transmission of hepatitis C is a much higher rate than it actually is. Oh, so it's probably roughly around 4 or 5%, give or take. Co-infection with HIV raises it up a little bit. But I think letting a person know that the transmission of hepatitis C from the pregnant person to the baby isn't that high. And then I would add, really supporting the person along the way to kind of cope with the stress of potentially transmitting the virus and waiting to see if the baby has it, that type of thing. I won't touch upon all of these, but the last one let's get into for sure. Oh, Andrew, I don't need to worry about hepatitis C. I've been vaccinated. Let a person know, hey, you've probably been vaccinated against hepatitis A or hepatitis B. We've yet to come up with a successful vaccine for hepatitis C. So come on in, let's test it. Test positive, we'll treat and cure you. Just letting folks know that interferon is out the door. In a lot of cases, ribavirin is out the door. Letting folks know that there is absolutely a cure for hepatitis C. Again, they might mix up hep C with hep B and that type of thing. And then making sure a person knows that, I don't need to test for hep C because I don't have any symptoms for hep C. Let them know that hep C is often asymptomatic. It's the same with when we're living with hepatitis C. You might not necessarily know it because a lack of symptoms or the symptoms are so vague, you might think it's something else. Let a person know that treatment and cure with or without symptoms is really, really important. And for a lot of folks, treatment and cure will improve their quality of life because some symptoms that they have that they think they just have because they're old or other things are related to hepatitis C. And they're like, oh, Andrew, I don't feel the fatigue. I don't feel the joint aches that I used to have after they've been cured. So that's a big piece as well. We did want to touch quickly upon hepatitis C amongst transgender individuals. We don't have as great data for this population as we need. And there are actually a lot of people who are very interested in this subject and are doing a lot of really great work. So I think the next time we do this webinar, we'll have more robust data and information. But, studies that have looked at hepatitis C have found rates ranging anywhere from a little less than 2% to nearly 16%. And again, in the general population, it's 1%. So I think this is the same recommendations we have for screening men who have sex with men, we should have for transgender folks. Once per lifetime, ongoing risk factors once per year. One of the things that definitely we should touch upon with transgender folks is when we talk about sharing of syringes, making sure we don't just focus on sharing of syringes around drug use, making sure that we also talk about sharing syringes for gender-affirming hormones, fillers, that type of thing, and knowing our resources around that. UCSF's Center for Excellence has some really great care and treatment guidelines, and then looking up potential drug-to-drug interactions with hepatitis C treatments and gender-affirming hormones that transgender folks might take is also really, really important to do. This is something you can look at. We talked about stigma, making sure that, the language that we use is open and we practice cultural humility with our folks. So using person-first language, making sure we have the preferred terminology on race, sexual orientation, gender identity, not just in the way that we talk to folks, but also with our forms, with the posters we have in our waiting rooms and our fact sheets and that type of thing, representing the diversity of our patient population. And then last but not least, using the right pronouns. Easiest way to do that is when you introduce yourself, introduce your pronouns. Hi, my name is Andrew, and I go by he, him, his pronouns. What pronouns do you use? And then you got that. And then if you misgender somebody, the best practice is apologize, correct yourself, and then just continue with your engagement with the individual. What are some common misperceptions you all hear and you want to talk about?
I mean, I could just quickly say, because this is also relevant to one question, the hepatitis C treatment and pregnancy misconception that it's never been done or that you can't do it. I think although the guidance does leave some room for joint decision making for sure, we do now have some data and you can treat on a case-by-case basis, or you can treat postpartum, or you can make the decision to treat after breastfeeding is complete. So I think that it's still joint decision making, but there's not an absolute contraindication to treatment in pregnancy.
Thank you, Doctors Lee and Kushner and Andrew, and many thanks to you, our listeners, for joining us. As a reminder to view the full program, Paths to Elimination, Simplifying Screening and Treatment of Viral Hepatitis in Priority Populations, please click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcasts on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.